got it.
Yeah, it's increasing.
Yeah. We have 1,500 registrations. I think we'll hit 500 again today, hopefully. How can we not hit 500 with this great panel today with us? So, good evening, everybody. This is the 32nd webinar of iBreastBook, and it's great to have a webinar with GReTA. It's a great team from Italy, has been always very supportive, have done great work with them, and they have great events. So we have Nicola Rocco from Milan. We have, from Napoli, Giuseppe Catenuto from Sicily, and Prof. Nava from Milan. And Nicola is going to give us the talk today. We have a great expert panel with us. We have Prof. Zoe Winters, we have Shelley Potter, we have Philip Stillert, Prof. Andrea Puzic, and we have also Michela Cinquini. This is a different webinar. The format of 3 talks followed by discussion. We're trying to do something different and see if you like it or not. So please, when you have the survey after the webinar, please give me some feedback if you like those different formats of doing the webinars, or if you don't like it, what has worked, what did not work. You will get a certificate with 1.5 CPD points from the Royal College of Surgeons of Edinburgh if you attend the webinar. Some people attend for 2 minutes and ask for the certificates. You will not get it unless you attend for a reasonable amount of time. If you have any questions, please put them on the Q&A section. And the chat is for the chat function. So you can chat as much as you want to the chat function, but if you want the questions to be answered, please put them on the Q&A section. It's great to see that there's already about 350 people online. We have the lovely Ricardo Pardo with us, and Ricardo has been a great friend and colleague, and he's going to do immediate translation to Spanish. So if you want to hear the talks in Spanish, click on the globe on the lower part of your screen and choose the Spanish channel. Now, we'll start with the first talks, and the speaker will be introduced by Giuseppe. Giuseppe.
Thank you very much, Yazan. It's always a great pleasure and honor working with you with the iBreastBook. This time, the speaker will be Nicola Rocco, who is the head of the scientific committee of the Fondazione GReTA. Nicola is a breast surgeon working at Federico II University in Naples. He's an expert also in methodology, has been doing several systematic reviews. And this time we'll be talking about the comparison between autologous breast reconstruction and implant-based reconstruction. So, Nicola, the microphone is yours. Thank you very much.
Thank you, Giuseppe, for your kind introduction. And it's a great pleasure to share with all of you the results of our systematic review on comparing implants versus autologous tissue flaps for breast reconstruction following mastectomy. We published our protocol as any Cochrane systematic review. The systematic review is preceded by the publication of a protocol in 2021, and we are working now at the final results that will be published in the few next months. I would like to highlight that the results presented in this webinar have not yet been peer-reviewed by Cochrane. So, if the final versions of the Cochrane review will meet the necessary standards, the review will be published in the few next months. Well, so we planned, in our protocol, we plan to include all randomized controlled trials, prospective or retrospective cohorts, comparing implants versus autologous tissue-based flaps for breast reconstruction following mastectomy for both breast cancer treatment and risk reduction. We consider to exclude all studies considering the simultaneous use of implants in autologous tissues, as in a latissimus dorsi plus implants, or secondary breast reconstruction, and all studies considering less than 100 patients. We included in our systematic review all studies about considering any implant-based reconstruction, so both 1- and 2-stage reconstruction, both in the prepectoral and subpectoral plane, both using or not ADMs or synthetic meshes. And we also considered both immediate and delayed reconstructions. We also considered any autologous tissue reconstruction, both pedicles and free flaps. We defined our list of outcomes, and we had our primary outcomes that are patient-reported outcome measures, we plan to include all studies assessing PROMs with the BREST-Q, the BRCA 31, or the EORTC QLQ BRCA 23, assessing all the domains, all the BREST-Q domains, that is postoperative psychosocial quality of life, postoperative physical quality of life, sexual well-being, satisfaction with breast, satisfaction with the reconstructive outcome, and the overall quality of life. Our primary outcomes were also surgical outcomes, like short-term complications and long-term complications. We defined short-term complications, those presenting less than 3 months from the operation, and long-term complications, those presenting longer than 3 months from the operation. Our secondary outcomes, also as suggested by a group of patient representatives that participated in the choice of the outcomes, were oncological outcomes, reintervention rates, the duration of surgery, the length of postoperative stay, the costs related to the breast reconstruction, and the aesthetic outcome not reported by the women. Well, we considered some confounding factors that may impact on the results of the included non-randomized studies. Those were the previous or post-mastectomy radiotherapy to the breast, to the chest wall, or the thorax. We consider also some comorbidities, diabetes, connective tissue diseases, and coagulation diseases. We also consider the smoking habit, the age, the BMI, and some breast characteristics as the volume, the ptosis, the breast tissue coverage thickness according to the classification developed by Alberto Rancati, and the breast vascularity assessed at the preoperative MRI. Well, we planned several subgroup analyses in our protocol. We considered sensitivity analysis comparing trials with low risk of bias compared with trials with high risk of bias. We considered to perform subgroup analysis comparing different types of breast reconstruction and also different techniques of implant-based breast reconstruction. We also considered different types of autologous tissue-based breast reconstruction, in particular free flaps versus pedicle flaps. And we also plan to compare radio-treated patients versus not radio-treated patients, obese versus non-obese patients, and elderly versus non-elderly patients. Unfortunately, we had several limitations. We'll have several limits in our primary literature included in the review. In fact, outcome data for most planned subgroups were not available in any study. So the subgroup analysis for the different timings of breast reconstruction, that is immediate versus delayed reconstruction, was not feasible, as the subgroup analysis on different techniques of implant-based reconstruction, as also the comparison between the subgroup analysis on radio-treated versus not radio-treated patients, obese versus non-obese, and elderly versus non-elderly patients. We also had some data about different types of autologous tissue-based breast reconstruction because some studies considered only free flaps or only pedicle flaps. So, other limits for our subgroup analysis were also the fact that most studies have been considered at serious risk of bias. Probably only 2 or 3 of the included studies were not considered as serious risk of bias, being considered moderate risk of bias. We assessed the risk of bias with the RobinSci tools, that is a tool that is planned for and thought for no randomized studies. So also the sensitivity analysis comparing trials with low risk of bias with trials with high risk of bias was not feasible. So for the only subgroup analysis we performed, I would like to tell you that no study offered data for any outcome separately for pedicles and free flaps in studies that considered both of them. But we only had some studies investigating only free flaps or pedicle flaps that were included in this subgroup analysis. And none of these studies offered data on PROMs. So we only had subgroup analysis for surgical outcomes and secondary outcomes. Well, let's look at our results. Our electronic search retrieved 6,298 records, We evaluate all these records, and we excluded 6,054 records on the basis of title and abstract. So we evaluated 244 full texts, excluding 197 full text reports because they did not follow our inclusion criteria. So we finally included 47 no-randomized studies in our systematic review. But let's look at the effects of intervention, starting from our primary outcomes. Let's look at the domains of the patient-reported outcomes. Well, we can start from postoperative psychosocial quality of life. I will show you the forest plots for any of these, or any of our outcome. And if you have familiarity with a forest plot, you can see how the diamond here favors autologous tissues. So we had 11 studies offering data on this outcome, and you can see how patient-reported outcomes for postoperative psychosocial quality of life are reduced when used implants. So this outcome favors autologous tissue breast reconstruction significantly. There is a significant difference in favor of autologous tissue-based breast reconstruction as far as postoperative psychosocial quality of life is concerned. The same is for postoperative physical quality of life. You can see that the confidence interval is very close to the line of the indifference, to the zero. Anyway, the P is significant. So we also have a significant value in favor of autologous tissue-based breast reconstruction for postoperative physical quality of life. I would like to tell you that all the included studies considered and used the breast Q to assess the quality of life. The same is for postoperative sexual well-being. The results favors autologous tissue-based breast reconstruction significantly. And also for satisfaction with breast, we have a result that is significantly in favor of autologous tissue-based reconstruction. And the same is for satisfaction with reconstructive outcome. As I told you, we do not have subgroup analysis for free flaps or pedicle flaps for these outcomes, as no studies offered outcome data separately for free flaps or pedicle flaps. Now let's look at short-term complications. Well, in this case, the results are in favor of implants, statistically significantly in favor of implants. So we have more studies offering data on short-term complication than on patient-reported outcomes. And we have a P of 0.03 in favor of implants. So short-term complications favors implants. And if we look at subgroups, and we had some data on short-term complications in the different groups on free flaps and pedicle flaps, we can see that the difference is not significant. This is because we included in this comparison less studies. And you can also see that the confidence interval in the previous forest plot was really close to the indifference. So, and we also can see from this forest plot, you can see here, comparing in vertical these two diamonds, that there is not a significant difference between pedicle and free flaps as far as short-term complications are concerned. You can see these data also in the test for subgroup difference. You can see that we have a P of 0.36%. So no differences in the comparison between implants and autologous tissues for short-term complications in these subgroups, and no difference between free flaps and pedicle flaps. But let's go to long-term complications. We can see that here the results is different because long-term complications favors autologous tissue breast reconstruction. This could have been predictable, but we will discuss it later. And we can see that the same is also for the subgroups, comparing free flaps and pedicle flaps. In both groups, we have results that favors autologous tissue, and also the comparison between the two groups is statistically significant in favor of autologous tissues. So Let's move to reinterventions. We can see that there is not significant difference between the two groups for reintervention rates. And the same is if we consider separately free flaps and pedicle flaps. We can see that there is no statistical difference in the comparison between the two subgroups also for the comparison and for the outcome of reinterventions. Let's go to duration of surgery. We can see that the results are highly in favor of implants with a statistically significant result of with a P that is 0.00001. So the duration of surgery, even if only 2 studies consider the duration of surgery as an outcome, is in favor of implants. I would like to underline how we considered our secondary outcomes, studies containing our secondary outcomes, only when they also offer data on at least one of our primary outcomes. So let's look at the length of postoperative stay. We can see that also the length of postoperative stay significantly favors implants. And the same also when looking at the comparison of pedicle and free flaps, even if we only have 2 studies in the groups of free flaps and 1 study in the group of free flaps, of pedicle flaps. So these are our effects interventions, and we will discuss now with all of you in the panel if we can rely on these results and what can be the messages for our daily clinical practice deriving from those evidence. Thank you.
That's a great up-to-the-point presentation, and that's the idea of this. So there's some people that are having problems with the audio. If you're having problem with the audio, make sure that you are on one of the channels, either the Spanish, if you prefer Spanish, or the English channel. Before we start the Q&A section, there's a little video, promotional video from the sponsor for the day, and then we'll go for the question and answer section. Many thanks for putting up with me for a couple of minutes.
Introducing the T-Stat 2.0 tissue oximeter for post-operative flap monitoring. T-Stat delivers continuous, non-invasive, and localized real-time spectrographic analysis and has been proven to be an easy-to-use and reliable tool for assessing the adequacy of oxygen delivery to tissue. Utilizing broadband white light to continuously monitor tissue saturation at the microvascular level on all skin types, T-Stat measures oxygen delivery to the flap in real time and has been proven to detect problems up to hours prior to other monitoring techniques, vastly improving flap success rates. T-Stat 2.0 measures both capillary-weighted oxygen saturation and hemoglobin levels, enabling surgeons to quickly decipher arterial versus venous occlusions and respond accordingly. The T-Stat monitoring system offers non-invasive, easy-to-place sensors, including a large surface sensor, a small surface sensor, an endoscopic sensor, and an oral sensor, providing a reliable and convenient monitoring option for any situation. And with OnCall, a web-based custom application by Spectros, surgeons have remote access to all of their T-Stat monitors. T-Stat data is updated every minute for real-time viewing and can be accessed with any Wi-Fi enabled or cellular device. With T-Stat 2.0, surgeons can improve outcomes and patient peace of mind while lowering costs and minimizing potential liabilities with a reliable, continuous, and accurate bedside monitoring system. T-Stat 2.0, to be sure.
Okay, can you hear me?
Yes, that's great.
Okay. So thank you very much, Nicola. Very interesting presentation. We know the data and we are not surprised by this data. We are now going to start with the debate. And as Yazan has already explained, this time the webinar will be a little bit different. We will have a guided debate. We will have speakers from an expert panel from with speakers from very relevant institutions. And we will be asking two sets of questions. The first one will be inspired by the GReTA, the evidence to decision framework. Is only inspired, we are not performing a grade here. And then we'll have general questions related to technique, to implementation of surgical technique within the context of a national health system and so on. So we'll have the first question that will be asked by Nicola, and all the speakers are invited to provide quick replies that will hopefully last not more than 2-3 minutes. Thank you very much. Nicola, the microphone is yours.
Thank you, Giuseppe. Yes, I would like to ask the first question to Andrea and to Shelley. Yes, well, we had a look at the data coming from the literature and our systematic review. And we also looked at the limits of the primary literature that we included in our systematic review. So I would like to ask to Andrea, would you trust the information we gained? Could it be useful for our shared decision-making process in our daily clinical practice?
Thank you, Nicola. First of all, I want to say congratulations on all this work. I'm so impressed by this, and also what a wonderful community of people coming together. I'm delighted to see there's almost 500 people on this webinar from all around the world wanting to learn about what our patients are telling us about the results of breast reconstruction. So I think just congratulations, and it's a wonderful thing to see that this is where we have evolved as a specialty and as providers. To your question about how do we use this data, I think my points would be, I think it's very, and I'll be brief. I think this data makes a lot of sense. I think it's like a lot of PRO data. Once you see it, you're like, oh, yes, that makes sense. It's exactly what I see in my practice. I think that the superiority of autologous reconstruction is something that we see, and that we sense that as clinicians, and this data solidifies that knowledge to understand. But I think as anyone who's practiced for a long time starts to recognizes that, I think the things that we need to be cognizant of, that the quality of our studies are ever improving, but there's limitations. So there are very few randomized trials. I think we have to just recognizing that this makes sense. This is a big step forward, but there are limitations. I think that also this is data that can be shared with patients, but should not be shared in the light of saying that only autologous reconstruction is worth doing. Not at all. I think many patients are still very satisfied with implant reconstruction, and many patients are also not candidates for autologous reconstruction. So it should be interpreted in that setting. But we can also help patients in shared decision making by saying, other women just like you, when we ask them a couple of years down the road, they do favor own tissue reconstruction, but they're also very satisfied. There's also great satisfaction also with implant reconstruction. It's just a comparison of the two. So, and I also just think we can use this data very strongly to advocate for patients with our healthcare systems. I think that is also a very strong use of this data and the work that you all have done. So congratulations.
Thank you, Andrea. So Shelley, what is your opinion about it?
I think Andrea's really said it all. The quality of the studies is limited, but I don't think this should be used to sort of say you should have an autologous reconstruction. This is about giving patients information and helping them to make an informed decision about what's right for them. Not all women will want or be suitable for an autologous reconstruction. Implants are a good option for many women, but when you're having a fully informed discussion with them, you can say longer term, women who have a tissue reconstruction are more satisfied. I'm a breast surgeon. I don't do autologous reconstruction, so I have no vested interest. But it is about information, and it is about fully informed consent. And I totally agree with Andrea. We need some well-designed prospective studies. I don't think we're ever going to get randomized evidence because that's just not appropriate. But we do need to be collecting this data robustly, prospectively, and then we can hopefully address Nicola's questions about subgroup analysis, women with high BMI, different ages, and then we can answer all the questions. But yeah, fabulous data, Nicola.
That's great.
Thank you. Thank you very much. So next question will be first of all, for Philip, and then for Zoe. We are talking about two techniques of breast reconstruction. Now, let's think about the spectrum of breast reconstruction and breast cancer priorities. Let us imagine that we are not only surgeons, but also we deal with public health. We are politicians. We deal with research institutions or companies. What priority, Philip, would you assign to breast reconstruction? Is it a priority in the development and research of breast cancer treatment?
Good evening, everybody. Congratulations on this nice study. But I do think that breast reconstruction is a priority. You know, it's the end stage after breast cancer treatment, and you know, the breast is a symbol for the women, so it should be a priority. And in Belgium also, breast reconstruction nowadays is completely reimbursed, which always has been a burden for the patients. So surgeons are not allowed anymore to ask extra surgical fees. And I think that's still a problem in worldwide. So it should be offered to patients, and it's definitely a priority also in the research field.
And what is the opinion of a breast surgeon, Zoe?
Yeah, I mean, I would echo what everyone has said. And, you know, in terms of the GReTA group, well done for taking this forward, because it's not always easy to do systematic reviews. I mean, at the end of the day, I think if I think about the bedside and when we're in the context of a woman needing a mastectomy, for myself and my colleagues and my oncology colleagues at the MDT, it's really the controversy about radiotherapy. Because, of course, with the advent of the AMROS data, now we have the 10-year maturation of the AMROS data, we're treating more axilla with radiotherapy. And of course, in that process, we are creating an implicit commitment to irradiate chest wall and regional nodes. And therefore, I can really speak for the practice I see in London. There is a lot of immediate autologous breast reconstruction going on. That said, you're quite right, there will be women that don't meet those criteria. But of course, we have the expertise of alternative donor sites like TUGS and SGAP and so forth. So for me, it's really what's happening in terms of the very early breast cancer trialist collaborative group, where that data is very historic now. And of course, we have the power of oncogenetics and being able to try to individualize that biological diktat better. But I think there's definitely a raising threshold for lowering the need for radiotherapy. I think there's a swing away from post-mastectomy radiotherapy. But in the MDT, I still find it quite difficult. And therefore, as clinicians working in partnership with our plastic surgical colleagues, we're kind of defaulting to the autologous on the off chance that there could be radiotherapy. We can sort of fall into a trap with invasive lobular cancers where we underestimate the axilla. We certainly try to integrate PET-CT in the context of better clinical appreciation of whether we could have missed an axillary lymph node. So for me, that's kind of the challenge. I think the big area that is going to be very exciting is the hypothesis that ADM could be better. There is no evidence for that at present. I look forward to that. And of course, the question or the dicta that everyone does pre-PEC versus sub, I think it is got to be finessed to a greater degree based on technical factors, and also the fact that certainly a pre-pectoral may be in favor of radiotherapy if that were required. There isn't a one-size-fits-all, and I think it behooves the big data registry approach, and that should be the way we practice anyway. We're still a long way off of that in England, both in the NHS and in the private sector.
That's great. Thank you, Zoe. Please, people that are online, please keep on the questions coming also on the question and answer section. So after the discussion, many of those questions will be readdressed to the panel. And now, was it Nicola or Giuseppe taking the next question?
Just a comment, Giuseppe.
Yes.
Yes. Giuseppe, your question was related in the health system about the time consuming. I mean, how many breast cancers can be treated with autologous tissue? That was the question, maybe above all.
Not really. It was in terms of priorities, in terms of research and development.
Yes.
That means that how much effort would you put in breast reconstruction as a priority, independently, irrespective of the technique you are going to use? That means that probably nowadays quality of life is one of the first goals for breast cancer treatment. That means that if breast reconstruction is one of the the way to get the highest level of quality of life probably is a high priority, like mortality in the old times.
Giuseppe, I have a question for Professor Nava now. Let's imagine that you have a patient that can be either a candidate to one or the other technique, so both through implants or autologous tissue. Do you think that the balance between desirable and undesirable effects, as I showed in my presentation, so the balance between patient-reported outcomes and complications and duration of operation, costs, and so on, would favor implant-based reconstruction or autologous-based on the choice between one or the other technique is rely on what for you?
But as you know, and I think people that are following now, I believe above all in shared decision making. So I try every time, and it takes me for the first consultation more or less 1 hour to try to get in touch with the patient and realize, according to the patient, which is anatomical feature, and take into consideration also what you quoted in your slides, complication. And so at the end, we can reach together a final decision making. That's the only way to work, I think. And then you can decide it which is better for your patient. But the main problem is that many people believe that to use an implant is really easy, compared to the autologous tissue. And I'm sure that from technical point of view, maybe, if I'm not totally sure. So the main important point is try, to believe that to choose an implant is not so easy. We have to go in depth with the patient, take into consideration what John Tebbets and Pat Maswell, teach us in which way we need to choose an implant. That's a really important point. And then share with the patient everything.
I understand.
Okay.
Please, Giuseppe.
Yes, this is very relevant, absolutely. And we have several questions also about this, or also about training, or about feasibility of the two techniques. Now I have a question for Shelley. And the question is, what would be the impact, in your opinion, on health equity of the two techniques in the context of a national health system? So we have implant-based reconstruction on one side and autologous reconstruction on the other side. What is the impact in terms of health equity?
Well,
Shelley?
I think in the UK, we've got a bit of a postcode lottery. We have data that shows that if you live in one region, you're more likely to get a tissue reconstruction. If you live in another region, you're more likely to get an implant. And that's because we have regional plastic surgical centres. In terms of costs, autologous reconstruction is front-loaded costs, but because you need fewer revisions long-term, the longer-term patient-reported outcomes are better. Autologous reconstruction is likely to be better for health systems longer-term if it's available. Implants are cheaper and quicker initially, but they will need revision over time, so they need constant investment. And we've got some long-term data that shows almost 20% of implants at 12 years are replaced with tissue anyway. So I think implants are potentially storing up problems for the future, and particularly in a publicly funded health service like we have in the UK, that's an issue. So what we really need in the UK is a bit of a reorganisation to allow women access to a full range of options, not just what's available locally. But although I think, again, it's about informed choice, it's about what's right for the patient, it's about all of that, but it's about equity of access. And I think autologous is a really, really, really good option because of all the long-term data. But that's not to say implants aren't a good option for some women.
Okay, thank you very much, Shelley. Let's go to the next question.
Yes.
Nicola.
I was thinking about other great domains. So I was thinking about the feasibility of one or the other technique. And I would like to ask this question first to Philip and then to Zoe. Which one of those techniques would you consider as the most feasible to implement in terms of surgical training, device availability, theater availability, also inpatient availability? We could think to implants because it could sound logical, but if you really want to get the best results, as Professor Nava underlined before, do you still believe that implant reconstruction needs simple training? And also the device has a cost, and inpatient time for autologous can be rather short nowadays. So it's not easy to choose between the two techniques. What is your opinion, Philip?
Nowadays, there are so many techniques available. So breast reconstruction is really like tailor-made. And it all depends, like Professor Nava said, on the correct, right discussion with the patient, what she wants, what are the expectations, what are the comorbidities, whatever. And regarding training, I think it's important to make young surgeons passionate again about breast reconstruction, because you see a lot of surgeons, they start to do breast reconstruction, they quit, they start to do aesthetic surgery. But the thing is also that you need to redirect those people, because breast reconstruction is very satisfactory. And in terms of training of implants, of course, it is easy to put in an implant, but it's not easy to do it correct. I always find it very difficult to do a proper, a nice reconstruction with an implant. I think it's quite challenging because the implant dictates the outcome. And when you do autologous reconstruction, you have those techniques available to actually minimize the impact of the implant. So, as I said, we're doing a lot of prepectoral reconstructions with fat grafting and implants, and we have some nice results also. These are quite straightforward techniques. I think it's also very important just to not to make your reconstruction too complex. We don't use ADM. I'm not a believer in ADM. I think it's also quite a big cost, and that's something that should be considered for the public health, because the cost of ADM is huge. And and also regarding autologous reconstruction, the training in autologous reconstruction, I think should be increased also internationally. Young people should be offered more fellowships to do microsurgical reconstruction, and we do see it in our department. We have a lot of people that have a lot of interest in microsurgical reconstruction, and those guys they go back and they start their own department. We recently had a wonderful colleague from Peru, and he was not supported by his hospital. He had to buy his microscope on eBay. Can you imagine? But these people are really passionate about the job, and think those people that we need, the attraction to go into aesthetic surgery is big nowadays. So, but it's still one of the most satisfactory disciplines in our field is breast reconstruction, and it is tailor-made, and you should be trained in both, I think.
Thank you, Philip, for sharing with us your experience. And what is the opinion of a breast oncoplastic surgeon as Zoe?
I think Philip has given a very good tapestry of that. I was just thinking as Philip was talking, and one of the things that strikes me is, if I think about implant reconstruction, I think it's one of the most absolutely exacting aspects, because even if, for example, you've got a sufficient skin fold thickness and you elect to put your prepectoral ADM total coverage, you may or may not over time then need to sort of consider that there is a loss or attenuation of overlying tissues. And therefore, just thinking about what Philip is saying, I could almost see, to absolutely optimize the excellence of implant reconstruction that you might get with an immediate autologous in the absence of radiotherapy, I'd almost like to have my bipartite relationship with my plastic surgeon in surgery to be able to do that fat grafting, perhaps at the time I'm doing a prepectoral, where the perception is my skin fold thickness is about 15 millimeters. It looks pretty good, but then I've got all the sort of immediate effects of edema, etc. So I think I'm concerned in England that folks are doing, even experienced oncoplastic surgeons are doing implant reconstruction. They might be committing women to contralateral surgery, which we know is not a recommended oncoplastic approach, but which is done simply to optimize the absolute symmetry, or the fact that we are, as breast surgeons, doing implants in the absence of immediate fat grafting, because I can sort of foresee For example, just anecdotally, a young woman with a BRCA mutation in whom there was no immediate donor site, and I could see that her skin fold thickness was prohibitive for a prepectoral. It would have been great in her to have had a plastic surgeon, consider whether we do fat grafting at that time, because otherwise my revisional approach is then to remove the implants, to then do my fat grafting on the current scaffold I've got, and to then reinsert implants. So there is no such thing as the feasibility or the feasibility of training in implants being less or a quick fix. If anything, I think it's a myriad of challenges in terms of the revisional aspect. But that said, if I think about the autologous with the rate of radiotherapy we are still adopting, which is probably about 30 to 35%, I hope that's going to drop with the current better chemoradiotherapy we're using. But with autologous, we're seeing the fat necrosis after the radiotherapy. We're seeing the induration and the edema after the radiotherapy. So to say that autologous is a free ride when we do have radiotherapy is absolutely not true. A lot of the surgeons I work with are absolutely at the top of their game. They're doing a sort of a double anastomosis every single time. They're doing bipedicled. So, whether the bipedical gives us less fat necrosis, I don't think we have data on that. So at no point do I think technically training in either is simple. I think it's cumulative over, decades, not a quick fix in any way or form.
Thank you for that, Zoe. I think it's a great point raised by both Philip and Zoe. Before we go to Andrea, I know that Philip might need to go early because they have other family commitments. Philip, it's an important comment that somebody like you say that it's not easy to do the implants, because for me, some of the best implant results I've seen in my life were yours with the hybrid reconstruction. And one of the most viewed videos and one of the most used webinars was the hybrid reconstruction, the beautiful results that you had. Where do you see that coming, the hybrid reconstruction? It's a bit of both, isn't it?
So what do you say? When do you see it coming? Or
where do you see the hybrid between pure implant and free flaps? Do you see the future that it might become hybrid?
The idea of hybrid originated from the idea that we are doing a lot of breast augmentations. So we have no problems in inserting breast implants in young women for an aesthetic breast surgery. And I was trained with the idea that implants should be avoided in breast reconstruction, because back in those days when you reconstruct a breast with an implant only, you have no tissue coverage. So the end result is a static breast. So now the breast doesn't look natural, she doesn't feel natural, it doesn't move natural. And in most of the cases, they put the implant in a submuscular plane. So the results are really poor, And now with lipofilling and fat grafting, we have that minimal invasive tool, because that's one of the topics in research also. We want to move towards less invasive procedures for the patients. And so lipofilling is a good technique because you are able to reconstruct already like a prepectoral volume, And then you can actually convert is a bit a strange word, your patient into some kind of aesthetic patient, where you do put your implant in a prepectoral plane. I think it's a good technique, mainly also in young women, like with genetic predisposition, because women in the 20s or 30s, they still want to have children, So you can wait, so you can perform that reconstruction with the hybrid technique, It's all about trying to control the impact of an implant. I think for me personally, before breast reconstruction with an implant was one of the most challenging operations, because you have the mastectomy, you have the skin flaps, and then you have your implant. It's always difficult to choose the right side of the implant, to put it where. You have complications with seromas, and you can't control the implant anymore. And with the hybrid approach, you can control everything. You have a complete control of the whole process, so you can build up a nice looking breast. And So that's why I don't like immediate direct to implant reconstruction, because I think it's very difficult and very challenging to have a nice result.
And that's an important message for everybody. So it's not as easy as it looks, as easy.
No, well, and that's why, because you were talking about training. It's all about training, trying to handle the tissues very properly, and I think it is quite challenging a direct implant, a direct reconstruction and implant.
So
thank you very much, Philip. I think there is a comment from Maurizio.
Yes, I think that after the paper published by the group of Brancati, related to the fat thickness, the so-called immediate breast reconstruction based on implant reconstruction is completely changed. The scenario is completely different respect to years ago. So nowadays we can really choose a different way between two stages, dual plane or prepectoral, thanks to this paper related to fat thickness between the skin and the glandular tissue. So the scenario is different. But I think that the paper quoted by Nicola has been published, years ago. Some of them are 2014. So we cannot compare today with 10 years or 15 years ago. So we have to talk about the paper published and quoted in the Cochrane study. I think so.
And that paper that you talked about the anatomy, we had beautiful presentation from Prof. Brancati a couple of weeks ago in the breast session. Beautiful. And there was lots of questions from people on where do we stop at the level of the mastectomy. You don't need to take all the fat. Fat is not breast. There is always a plane, and you need to find that plane. And the most important part is your mastectomy.
That's why.
Yeah. And Prof. Puzic, you wanted to say something, Andrea?
After Zoe's comment, I just wanted to add in, I completely agree. I think the autologous reconstruction followed by radiation is a disappointment and a missed opportunity. I think we have to be I think in the setting where we don't know if a patient is going to require radiation, I think it's reasonable to consider autologous reconstruction. But when we know a patient is going to receive radiation, I think it really gives us pause, and we should be thinking about the negative implications of radiation, of radiating a flap. I think also just the radiating an implant is the other, we know that based on sort of the Mastectomy Reconstruction Outcome Consortium data, and as also seen here, that these are patients who will have the worst outcomes, will be the radiated implant patient, and close to 1 in 5 will actually lose their implant reconstruction at 2 years. So I think that it also gives us pause. So Zoe, I completely agree with you. And my hope would be is that similarly, that as we become more sophisticated in our ability to treat the cancer, that radiation we will be more judicious, or that radiation will be considered more closely, and because the long-term implications are very significant. The one other question I would like to put out for the group that hasn't really come up in this review is the impact of donor site morbidity. I think so. While we're talking about how important, that there is this superiority of autologous reconstruction, both in, the quality of life outcomes and long-term complications. And I say this as a microsurgeon who does a lot of autologous reconstruction plus implant reconstruction, is that one of my disappointments is when I see an abdominal bulge, or I see changes in abdominal wall function, and I think that is also part of shared decision making. And in the MROC, Mastectomy Reconstruction Outcome Consortium data, we also saw that at 2 years, that there was a diminution in abdominal wall function. Which isn't to say that we shouldn't be focusing on this approach, but we also, I think as a specialty among plastic surgeons, is to continue to refine our techniques to minimize donor site morbidity. And perhaps this is where lipofilling and fat grafting may ultimately evolve to be the superior approach. And I don't know that yet, but just to put that out there in terms of donor site morbidity.
That's great. One last question from the floor before we go back to the regular questions. Prepectoral or subpectoral? A question from Eris Sutton, who's working in the Emirates now, and that will be a very frequent question. Shelley, you want to take this?
We don't know. There is no good evidence to suggest that pre-pec is any better than sub-pec. We have data from the UK, from the iBreastBook study, and now from the pre-breast study that suggests the short-term outcomes and also the 18-month patient-reported outcomes are very similar between the two groups. So I think we need some randomized trials, and we have one in the UK called BESPRA, and there's also Water-Webber's international trial as well that's going on. So I think it's a case of watch this space. We need some evidence.
That's great. And we'll go back to the question and answer that are already arranged by Nicola and Giuseppe. Nicola and Giuseppe, it's all yours.
Okay, thank you very much. Very interesting discussion. So my next question is to my friend Nicola. We have been discussing for a long time the results of this systematic review. And I want to ask you, Nicola, what is the major limitation? What major limit did the included primary literature show, in your opinion, in this work?
Well, unfortunately, many limitations in our primary literature, not only one major limitation. Anyway, if I could comment on these, I think that a major limitation is in the fact that no study offered outcome data on the relevant subgroups, as I underlined, and as also Professor Winters and Professor Pusic underlined, we need data on radio-treated patients, but we could not perform subgroup analysis on this group of patients, as we do not have separate data for outcomes in radio-treated versus not radio-treated patients. So this could also be a message for future studies that we could perform, that researchers should offer data on these subgroups, also on obese patients or non-obese, smokers versus non-smokers, considering offering separate data, outcome data on all relevant subgroups that could be for all those characteristics that could have a major impact in the decision process. But there were, yes. Oh, there were also some major limits also in the assessment of the quality of life. In fact, we had the assessment of the quality of life and the use of the breast-Q at different time points, at different follow-ups from one study to another. And also we had a strange use. I would like to ask, we have with us Professor Pusic that developed the breast-Q, and I would like to ask her, many studies did not consider all the domains of the breast-Q in the assessment. Is this an improper use of the breast-Q? Why not applying all the domains?
I'm happy to answer that. Thank you. No, it's actually perfect in many ways. The breast-Q is designed for, it's a pick and choose menu of what's most important relative to the study that you're performing. So an example, so we really designed it so that you could say, if what you're really looking at was, say, patient satisfaction with breast and psychosocial well-being, sexual well-being, you look at that, I would consider that body image, those three scales together. Perfect to just use those three. If you are interested in, say, donor site morbidity, you might use physical well-being of the abdomen. It can be used alone. If you were doing, say, a quality improvement initiative in your hospital, then you might want to look at patient satisfaction with information or patient satisfaction with interactions with the team. We designed the breast-Q so that it would not be burdensome to patients, and there's no need to administer all the scales. What one shouldn't do is to pick and choose the questions in a scale. That's different, and very few people do that, I think. And so that's, but really, I actually encourage people to pick only those scales that are most relevant to the question that they are. And the same way in any scientific experiment, you would pick the outcomes you're most interested in.
Thank you.
Thank you very much, Nicola. I have another question for you. Sorry, thank you very much, Andrea, and also Nicola. And I have a question for you both. Nicola, can you explain us why only postoperative scales were included in the review? And do you believe that the correct estimate for quality of life would be the delta between the pre and post-op values of quality of life? Obviously, the question is also for Andrea.
Yes, no, there is an easy answer, because primary literature only offered data on postoperative quality of life. So there was not a baseline value assessed. There was not the assessment of the preoperative quality of life. As for your second question, I would like to ask to Andrea Pusic the answer, because is that correct to use only the postoperative quality of life, or we should consider the delta between pre and post?
I think it's the delta is the short answer. And the example I would use is, again, the mastectomy reconstruction outcome consortium studies that I led with Dr. Wilkins. And what we saw is that, so if we looked at the 1 and 2 year outcomes, and I'll just take, for example, patient satisfaction with their breasts. So what we saw is that patient satisfaction with breasts was higher post-operatively, autologous versus implants. What we saw also is that patients, if you look at the pre-op, the autologous reconstruction patients actually came in with lower breast satisfaction compared to implant breast reconstruction. And so the delta was actually more significant. If you think of pre to post, an autologous reconstruction, the patient starts lower and they go higher. An implant reconstruction starts higher and they still end up at a place that was basically where they started, which I think is very good news. And I think that needs to be part of the message to our patients, is that implant reconstruction still does deliver a good quality of life and body image. But if you look at the delta, that it further favors autologous reconstruction. And I think what's happening there is that women who are good candidates for, say, a DIEP flap or a tram flap are often women who are, they are heavier, they have a higher BMI, larger breasts, and they will have a flap reconstruction and then also have a contralateral reduction. And so they actually end up being happier from a body image perspective because you're really picking up on the breast reduction effect, because they now have smaller breasts and had a lift as well.
Perfect. Thank you. Thank you. It's really an honor to have the opinion of who developed the breast Q. Yes, very useful for all of us. So, Giuseppe, I go ahead with some other questions. So we saw that we have many limits in our primary literature. So I would like to ask Shelley, you are a study designer, you design research and studies. And how would you design a trial investigating on quality of life? How to improve trial design in this field? What type of study would you design? What population? What interventions? Please give me your opinion about this.
As I said earlier, I don't think you can do an RCT comparing different techniques. I think patient preference, surgeon preference is too big an issue. So if you're going to do an RCT, it will be comparing smaller things like pre and subpectoral reconstruction, and there are several ongoing trials with regard to that. I think if we're going to be looking at reconstruction outcomes, we should be looking at large-scale prospective longitudinal studies, including preoperative assessment of quality of life. As Zoe said, ideally registries. We capture everyone, we're not getting selection bias, and we get that longitudinal data so we can track things over time. So I think trials in reconstruction have a very limited place, but high quality, well-designed prospective cohorts, ideally within registries, would be ideal, with long-term follow-up to 5 and 10 years and hopefully beyond.
Agree. Thank you.
Thank you very much. Very clear message. Now I have two questions. Two questions for Andrea and Zoe as well. We are in absence of preoperative data on quality of life, considering it does not seem possible to assess results using only post-op, as you correctly explained us. Is there any available standard table normative preoperative values, Andrea, of breast Q?
I can, I'd be happy to share those with the group. We did do normative data. They are in the published literature. What we did is we essentially, we surveyed women that did not have breast cancer. So just essentially trying to understand the experience of patient satisfaction with the women. I said patients, women, what a normative value for breast satisfaction across women in the US effectively. So I think, again, I do think that in any study you do, you'd actually would like to have the preoperative of that patient sample and look at the delta. In the absence of that, we have normative data for just women in the general population, how they would answer the breast Q.
Yes, obviously this is related to different population. You cannot have normative data that can be suitable for European or North American or South American. It's really related to the population you are going to investigate in your trial.
Which is why it'd be better to collect your preoperative in your own study. And so in a registry model, which again, I could not agree more with Shelley, I think but in a registry model where everyone was completing a preoperative assessment and then being followed postoperatively, that would really be ideal.
Zoe, what is your opinion about this?
I mean, that's how, within the EORTC context and when we were developing BRecon 23 over about 8 years. I mean, it's key that each patient is their own control. And clearly, as Andrea has said, that baseline is going to be intrinsic to that person's perspective. So, you know, you've got a cumulative timeline, and when you're looking at the science of quality of life, it's about that change over time. I became very interested in, you know, minimally important difference, because in quality of life, what is clinically significant? And so one of the key aspects, and I know that this was something certainly that we unmasked in our last paper, which was our final development paper, or our phase 4, was that when we were doing BRecon, we clearly had categories that we predict. So there is a priori hypothesis that, for example, surgical complications are going to lower your quality of life. And we actually then look at how the domains and the items, or the items within the domain, and how that domain is comparing. So we have surgery complications, no complications, radiotherapy, no radiotherapy. And we saw that our model predicted extremely well. So it met all the criteria for sensitivity and specificity. But, you know, then when I left academia, it still was very key for me to think about, you know, how the progress is in science in terms of what is clinical significance in quality of life. And I think what amazes me in a lot of the studies is that there is poor scientific methodology around quality of life. And I think it's, you know, with Andrea in Boston and Harvard, it's absolutely key to have your statistician who is qualimetric, because so many folks are simply reporting, and they're reporting a percentage of something, which is absolutely horrendous. So I do think that quality of life is not the same in every publication. You've got to be very careful of that.
Okay, so thank you very much once again. So if we go to morbidity, one of the most important differences in the comparison between implants and autologous is clearly related to abdominal morbidity. And apparently there is no assessment of abdominal morbidity on implant-based reconstruction. The question is for implant-based reconstruction. So there is no comparison in the systematic review because there is no assessment. How would you estimate abdominal morbidity for implant-based patients with a breast skew? Is it possible to estimate? Because in the comparison is one of the most important aspects that may favor implant-based reconstruction. So the question is to Andrea again and to Zoe again.
Physical well-being, I think.
Yeah. I can, so to comment on, so there's no reason to think that a woman's abdominal function would change because she's had an implant reconstruction. So if you did a baseline assessment of all your patients who are having implant reconstruction, you could maybe do it again at 2 years, but I suspect it would stay about the same. What we did see in the MROC study is that there was almost a 10-point difference in abdominal wall function at 2 years after abdominally based autologous reconstruction, which I find very disconcerting and has made me change my practice. I mean, I just work a lot harder to try to save the nerves, and it has slowed me down in the OR, but it's been worth it, and the data is the reason. So I think in the comparison, I think a good study would be to look at the abdominal wall function in implant reconstruction compared to autologous reconstruction. But again, going back to your point, Giuseppe, it's the delta. It's not about the woman who's having autologous reconstruction is contemplating that, but I need to be able to say to her, this is where you score now, and this is where I think that there is a diminution. Where I struggle is how to communicate that to patients. Because I say this is the best reconstruction from a breast perspective, but also in my own hands and in the research data, we see that some patients will experience a change in how their abdomen feels and functions. And then they say, what do you mean by that? And I struggle still and I think there was a comment in the chat about the role of qualitative research. I do think that is perhaps where the qualitative research continues to be something we can push along, because, and also there's a lot of comments have been made about the importance of shared decision-making. I would love to see more research and also guidance. I would appreciate guidance about how best to communicate this to patients. So communicating PRO data to patients is still a challenge. As clinicians, we can say, here's the MID, this is what we perceive. But then if you really want to take it to the next level, I think we have to understand, how do we share those, what the meaning of those numbers with patients?
Thank you very much. Zoe?
Sorry, did you ask me a question?
No, the question was also to you, because you are an expert in estimating quality of life. You cannot make a comparison in abdominal function if you haven't tested abdominal function in implant-based patients.
I think what I would say is, when you are setting up a study, look, it's different if you're in a registry. There will be domains that are relevant to some women and not others. And I don't really think that's a valid comparison, really. So I wouldn't be focused on, for example, that domain as my primary outcome. So the key thing in a prospective cohort is to define what that pertinent primary outcome is. Clearly in cancer, we know it's going to be, distant disease-free overall survival, etc., breast cancer-related survival. The same in quality of life. You want to create, or you want to have a common domain that is going to be bespoke to every woman in that trial. So that's where the quality of life studies are really so important, to work with leading scientists in the field. And that's not just capturing everything. You clearly in a registry are going to capture everything, but then you are within your registry, you define your quasi, it's almost like a quasi-randomization. So exactly as we would design a randomization trial in a cohort where you've collected everything, you would have a sub-study or a trial within a cohort, which is in fact a grant that we wrote called TWIX, Trials Within Cohorts. So effectively, you would then hypothesize your primary outcome measure, and that would be a relevant domain for that scientific question. So I wouldn't be saying that that's a really relevant clinical interpretation for abdominal physicality in somebody who has implant versus a donor site, because it's not intuitive.
Thank you very much, Zoe. Thank you very much. So we'll go for the next question. Nicola, please.
Yes, Professor Nava would like to tell something about this. Yes. The microphone is off. The mic. Okay.
Just a comment. Maybe we need to investigate not only the abdominal function, but also the cosmetic outcome. The shape of the abdomen can change. We carried out a study at the National Cancer using TransLab, and sometimes one of the problems related with the patient was the final shape of the abdomen that changed completely. So I think that we need to take into consideration many different, aspects, not only function, but cosmetic outcome too. So are really important if you're talking about breast reconstruction.
Yeah. I also have another question for you, Professor Nava. We all know that during your career, you optimized breast reconstruction with implants, obtaining excellent results. However, since the late 90s, we are using more or less the same devices, maybe with minimal adjustments. Do you believe anything is going to change in the next few years in terms of shell shape, filler materials of implants?
As everybody knows, I was an allergen user. Nowadays we cannot use anymore, and so I try to change my way to work on it. I open my mind in different shape. It's a very, very difficult question. What will change in the future related to implant? Maybe, with the so-called light compared to the weight, final weight, can improve the final outcome in breast reconstruction above all. But again, I think that in the last 15 years, we didn't change in terms of implant shape and implant, material. So again, what John Tebbet's chart in aesthetic and Pat Maxwell in reconstruction is still really important. And the main important thing when we are using implant is try to change and not think about size and volume, but measure. Still, again, measurements. That's the only way to approach by using implants, you know.
Okay, thank you.
Thank you very much, Dr. Nava. My opinion is that we are using very old devices, and these are not anymore acceptable if you want to get acceptable results in terms of quality of life. That should be a major involvement of the companies, and we need a lot of research. We are still using balls filled with silicone, and clearly, if we are not going to change this, there will be no gain in terms of improvement in quality of life, in safety, in final cosmetic results, and so on. This is my point of view, obviously. I'm not sure we can generalize the practice of autologous tissue, and it is really time consuming. It is excellent in certain specific situations, but we need really something that can be offered to patients in the same operating theater time, especially in the context of a national health system. But this is really my opinion. Then I have a question to Shelley as an oncoplastic surgeon, to Andrea Pusic as a microvascular surgeon, and to you, Professor Nava, as one of the founders of implant-based reconstruction. The question is, what would you envisage in the future of autologous breast reconstructions? Will it be a more popular and straightforward operation? What do you think? Let's start from Pusic first.
I think in my mind, I think autologous will evolve to be something that is more broadly accepted, more broadly accessible. But I think we have to solve the donor site morbidity issues. I do wonder if in the future state, fat grafting and becoming more successful with our fat grafting such that we perform an entire breast reconstruction with fat grafting alone. There's been some interesting work in that regard recently. That if I had to envision, it would be an autologous reconstruction, but with no donor site morbidity. And I think fat grafting probably comes closest on that. And yet we are still failing to do that in a reproducible manner. So that I think that's where the future lies. I agree with you that there has not been a lot of progress on implant reconstruction. Regulatory issues are kind of at the center of that as well. But those are my thoughts.
Thank you very much, Andrea. Very clear answer. And now the opinion of Shelley as an oncoplastic surgeon.
I completely agree. I mean, we need implants that don't have the issues that implants currently have. So think about bioengineering and the possibility of 3D printing and biological implants going forward. That's potentially the future, which would be an autologous like-for-like reconstruction without any donor site morbidity. So that's what we're going for ideally. Fat grafting in an NHS publicly funded setting is an issue because of the multiple operations that you need and the costs and the resource issues associated with that. But I think science is going to be the answer with bioengineering implants. Yeah.
Nava, your opinion now as the implant expert.
I started years ago when I was at the National Cancer using tram flap above all, and I tried to involve young people with microsurgery, as you know, Giuseppe and Nicola, you know. But nowadays, the scenario is completely different, as Andrea said, and Shelley too. Now we use bioengineer or what we call hybrid breast construction, and putting together, ADM or non-reabsorbable meshes and fat injection or fat grafting, we are not so far by what we call, autologous and implant. Nowadays, we can reach the goal to have 50% of fat and 50% of implant as a final size. And it means as in aesthetic breast surgery, when you have a small breast and you put an implant prepectoral by using fat injection. So again, it's not so easy nowadays to say that we have a great difference, in terms of using an implant is very easy. We can do in a very easy way. Instead, it's very difficult to use a tram or you need to be taught, obviously, in what we call microsurgery. But the two different options are a very important, planning before and execution during surgery. This is mandatory. This is my personal opinion.
Thank you.
Thank you.
Nicola.
Yes, we move on with some other questions for all the panelists. I would like to go to complications. Well, some reviews or some studies in the literature reported higher total failure rates for implants. This information is misleading because we know that there is no comparison in terms of damage when it happens to an abdominal flap or to an implant. We know that when the implant is lost, you can use a flap, or you can try again with an implant. But when a flap is lost, you waste a major surgery. You need to find another donor area, or you may need an implant. So I think that failures are not comparable. What is your opinion, Andrea, Shelley, Zoe, and Maurizio?
I would say that actually an implant loss is just as devastating to the patient. I know that in terms of your abdominal resource, that's a major problem, but we did a qualitative study with women who'd lost their implants, and it's a devastating thing that has a really significant impact on their well-being. So I don't think it should be underplayed. Having a reconstruction that fails, whatever the reconstruction, is a total disaster. So we should be having meticulous techniques that reduce the risk of that. And I don't think we can overstate what a huge impact losing any reconstruction has on a woman.
Yeah. What do you think, Professor Piesic?
I just think Shelley is spot on. I think so as a surgical team, when we lose a flap, we talk about it forever. We go over it and over and over again. But a woman loses her implant, it's like, oh, we'll book her at the end of the day. We'll take out her implant. For each woman, it is equally significant. And I think because when we're doing a 6 or 8 hour autologous reconstruction case, we pour our hearts and souls into that, and it reflects surgeon bias to think that somehow the loss of a flap is a bigger event than the loss of an implant. So thank you, Shelley, for making that point. I completely agree. I think the rate of implant loss is lower, full stop. And we know that even in a center that doesn't do a whole lot of implant reconstruction, you might say 5%. Whereas again, I think implant reconstruction, we lose a lot more implants. And then if you add radiation in, it's very significant, and something that's in the double digits, which I don't think we share that information very, very frequently with patients. And certainly a woman who then has started along the path towards implant reconstruction, and then we learn that she is now being offered radiation. I think it's really important that she understands the quite high likelihood that she may lose her implant, and that is devastating.
Yes, I see. What is the opinion of Professor Nava? The microphone.
Totally agree with Shirley and Andrea. Is a drama, and we haven't to forget our promise to our patient at the beginning. Above all, when we are talking about oncoplastic, sometimes a great word, but unfortunately used not properly in many times. So again, we need the shared decision-making, taking into consideration the drivers. If you don't analyze all the drivers related to the oncological point, reconstructive and patient wishes, it's hard, to reach the goal and to try to avoid complication, definitely.
Okay, thank you.
What is the opinion of Zoe?
I see Zoe is still with us.
No, I think Zoe had to leave, so she just texted me a couple of minutes ago. Apologies for that.
Okay. Right. Okay, we can go to the next question, hopefully, and then close probably.
Yes.
So next question would be, is something related to research. And we are going to talk about capsular contracture, which is one of the most important issues related to implant-based reconstruction. And the question is to Maurizio and to the other colleagues that we have on the panel now. What about pharmacology, use of drugs? Because you know that drugs can be randomized, and you can use randomized trials in terms of methodology, of course. What about drugs to prevent and to reduce capsular contracture? Your opinion, Maurizio.
But as you know, we published a paper together with Nicola related to the use of mitomycin C when we removed the expander before the permanent implant, we didn't find any, data that we can use this kind of drug using different other surgical procedure to try to reduce capsule contraction. I think that it is a combination of different way to work on each, I mean, to choose the right implant and on the bigger one respect to the, pocket that we are doing by using a so-called 12 to 14 point published by Diva or by Bill Adams. And we can use also in reconstruction, just for give you an example, when I'm doing an immediate breast reconstruction, I use trial prosthesis. So I can avoid any damage to my implant, rupture. We know that 90% are instrument damages. And in the same time, I can follow the 14 point. So try to reduce contamination. I can remove my trial prosthesis just before to insert my permanent implant. So if we try to follow all these kind of different procedure, we can reduce. And nowadays, by a combination of, try to reduce contamination, ADM or synthetic and lipo, we can really reduce the final percentage. And now we are not so far from 20 years ago in aesthetic surgery. It means 5 to 7% of different, and maybe I can suggest to Nicola to, investigate with the Cochrane system, the real complication of, if we can, I don't know. So this is my opinion. Using many different, surgical procedures and approach, you can really reduce this kind of problem. It's
Shelley,
not an issue nowadays.
Shelley, thank you very much, Maurizio. Shelley, what is your point of view in terms of pharmacological research to prevent capsular contracture?
That's really not my area of expertise. It's probably something that's very amenable to research, but it's not something I have much expertise in. So I will defer to people with greater knowledge on that one.
Andrea? Your microphone is mute.
I apologize. I was just actually trying to answer a question in the chat, and then sending a reference across to someone. So can you just ask me the question again?
Yes, the question is whether you see any space, any possibility to perform pharmacological research to prevent capsular contracture for implant-based reconstruction. It is something that can be investigated. It's something that could be put into a randomized trial, for instance.
I would love for us to find some solutions to that. I think probably one of the steps that has to happen to facilitate that, though, would be to develop better ways of evaluating capsular contracture. I think the Baker grade is notoriously, it's good to have that. It's not as reliable as we would like it. If we're going to do rigorous research to evaluate capsular contracture, just one of the hindrances is the unreliability of the Baker grade. I would love to see the science evolve, but just like in the same way, like when we developed the breast Q, it was to be able to start to rigorously reliably measure the patient perspective. If we're going to evaluate capsular contracture, we need to be able to rigorously, reliably measure that outcome as well.
Thank you very much. Nowadays, today we discussed about priorities in breast cancer treatment, and we decided that breast reconstruction is one of the priorities. So why not investigating molecular signature for capsular contracture? Maybe it could be something interesting to be investigated. And I think we can go to the last question that can be the final summary of this interesting debate. Nicola, do you want to ask?
Yes. We know that actually we are using more and more primary systemic treatments, and primary systemic treatments are more and more effective. We have very good screening services, and we also are using so-called extreme oncoplastic surgery also to treat in a conservative way multiple ipsilateral cancers. So don't you think that the use of breast conserving surgery could be the best alternative to poor reconstruction? Don't you think that reducing mastectomy rates could be the best alternative to complex or poorly effective breast reconstruction. What is your opinion about this, Shelley?
I would wholeheartedly agree. I think we need to use more neoadjuvant chemotherapy, more neoadjuvant endocrine therapy, reduce mastectomy rates, better use of oncoplastic breast conservation, both volume replacement and volume displacement. Mastectomy should be the last, absolute last resort. And then I think a lot of these issues will be addressed, because many of the oncoplastic techniques give you better outcomes. So yes, fewer mastectomies, I think, is what we should be aiming for.
In other words, breast conservation is the best autologous reconstruction.
Yes, there's nothing better than a natural breast. There just isn't.
Okay, what is your opinion, Maurizio?
Totally agree. If we can try to go ahead in this way by using different kind of neoadjuvant, treatment, but we haven't to forget the patient wishes. Because sometimes the patient, for peace of mind, refuse radiotherapy, many other things we have to take into consideration. And the patient asks for a mastectomy, we have to try maybe using a counseling with the psychologist intervention, but we need to take into consideration patient wishes.
Definitely.
Thank you very much.
But we also need to think about the data, because there's increasing data to suggest that breast conserving surgery plus radiotherapy is oncologically better as well. And a lot of women's desire for mastectomy is born out of fear. So if you can actually rationalize that, a lot of women will no longer want it. But there's obviously going to be gene carriers and those sorts of things that.
Yes, this is another issue, because by the time we will increase with identification of gene carriers, we will be performing more bilateral mastectomies. This is a contradiction. So less mastectomies for cancer, but more mastectomies for prevention is absolutely a contradiction. Definitely, we need to clearly identify patients who will require a treatment, or patients who should be monitored long term. I think we can conclude here our debate. Yazan, what do you think? Is there any question from the audience?
There's a few things from the audience that I want to comment on. Andrea has been great, has been answering things online, and many people have been helping answering online. Just a little comment, Marco Miel from Denmark. It's great to have you, Marco. The same comment that Nicola mentioned. The aim is to try to reduce mastectomies, and with all modern techniques and modern immunotherapy and treatments, hopefully the mastectomy rates will get less and less. A comment for somebody asking about risk-reducing surgery. What's the better technique for risk-reducing surgery? There is no black or white, which is better, which is not better. There is always shared decision-making, and there's always need to discuss all the options with the patient, and they'll decide. And nearly everything has been answered, so it has been great having you all on board. Now, I think Giuseppe and Nicola, you want to share a couple of meetings. Please remember, in 3 weeks' time, you have another webinar, and the webinar comes back to the same format of 3 talks. It's a webinar with the team from EU Breast and with the iBreastBook. We're going to talk about new localization techniques. So we're going to talk about the MACSeeds, the radiofrequency tags, all the new techniques in breast surgery for the breast and for the axilla. And we'll have great speakers and panelists with us there from the UK and Europe. So it will be great to have you on board. Everything is free. Everything will have CPD points. And Nicola or Giuseppe, I don't know who's sharing the CBM meeting for 2022.
Thank you very much, Yazan. Yes, first of all, I would like to thank all the speakers and the panelists that have been on this webinar, and I want to invite all the participants or the members of the audience to this very interesting masterclass that will be held by GReTA in cooperation with the University Campus Biomedico of Rome, that will be in Rome on the 7th and the 8th of October. And Maurizio Nava, Nicola Rocco, but clearly also Yazan will be one of the speakers. It will be an interactive masterclass, and there will be direct involvement with senior speakers. So the program will be soon online. And then the second important issue is that, as you know, every year we run an international fellowship that is based in London, in Cambridge, at the Royal Mass, at the Addenbrooke's Hospital. The job description is online. There will be a 2 months observership in Italy at the National Cancer Institute and in New York at the Memorial Hospital. And if you want to apply, we are always pleased to have a very wide field of applicants. And we normally have a very wide field of applicants with excellent guys coming from all over the world. Thank you very much for the attention. And Nicola and Yazan, the word is yours now.
That's great. It's great to have you all. Barka, Sajid, that's the one that's a fellowship that we were talking about in the chat function. So we'll try to share that in the next newsletter. Andrea, Maurizio, Nicola, Zoe, Shelley, and Philip, it has been great pleasure. Many thanks for giving up your evening again to be with us on the iBreastBook and the GReTA webinar. It's great to have people. I had people from Australia logging in at 2 o'clock past midnight, and Amir is still online. He finished the whole webinar. It's great to have people from all across the world. We'll be waiting for you for the next webinar on the 16th of July, and we'll be sharing everything in a newsletter. So for people in the States and South America, have a lovely day. People in Europe, have a good evening. People in the Middle East and the subcontinent, had a good night. Thank you, everybody.
Thank you.
Thank you. Bye-bye. Thank you, everybody.
Thank you, Ricardo.
Bye. Thank you.
Muchas gracias.
Hey, Jack. Bye-bye.